I'm going to present our philosophy of treating Keratoconus now. So, just what is the prevalence of Keratoconus? So there is different studies showing that there is probably one patient in population per 500 to 2,000. So we don't know exactly, but for UK, I counted, I don't know if you have better numbers, but it can be 60,000 to 100,000 patients, which is quite a lot of patients. Then we know that there are biomechanical changes in the cornea. We know that there is a decrease of biomechanical stability, and then we know that there are anatomical changes, corneal bulging, thinning, corneal scar formation, and then we know that there are also changes in keratometric changes, increase of anterior and posterior elevation, and increased keratometry. We know that there are refractive changes, myopia, or very often also hyperopia. It depends where the patient is looking actually. And we know there is astigmatism, increased eye order aberration. And finally, for the patient, it means decrease of visual acuity, decrease of contrast sensitivity, increase of photophobia, glare, diplopia, and distorted images. What's the difference from the old times? We can act in these four, actually, places we can act. We know the treatment where we can intervene. So, talking about the new strategy in the treatment of keratoconus, now I divided actually this strategy in two phases. The first one is tectonic phase, or we can call it corneoplasty. So we want to do biomechanical stabilization of the cornea. So this is the first step. And the second step in this first phase is regularization of the corneal shape. Then, after we are able to reach these first goals, we can go to the second step, which is refractive phase, and to correct refractive error. So what concerns biomechanical stabilization of the cornea, first we have corneal cross-linking. Probably you've heard about it, and you know that this is a new treatment. And actually what we know now, so there is this destabilization of the cornea. So you see that the cornea is actually there are the lamellae which are running from one side to the other, and there is some sort of slippage of these lamellae. So the cornea becomes weaker, and so that's why the cornea is bulging. So there is something in between the lamellae, what we call crosslinks, and these crosslinks are making the tissue stiff or stiffer. Unfortunately, it was Theo Seiler who was his dentist, and then you know that when they are doing these white plums, you know, so the fillings, and they are like putting this white stuff, and then they are enlightening it with UV light and making it harder. So then he was thinking, why not to do something like this in the cornea? I was doing the same research, but other way around. In ocular cicatricial pemphigoid, I was trying to actually break corneal crosslinks. So, unfortunately, it was him who invented it. And so, the treatment actually is, so that we are using now the riboflavin. We are infiltrating the cornea with this molecule, and then we are using UV irradiation, UVA, to produce oxygen radicals. Actually, this is all we are afraid. We are always afraid of UV light, cornea, eye, but in this case, actually, we want that. Actually, riboflavin doesn't allow to penetrate UV light across the cornea. So it's all the UV light actually stops in the thickness of the cornea, and it induces by the production of oxygen radicals. It uses new corneal cross-linkings in the cornea. So you see, after cross-linking, we have more. After cross-linking, we have more cross-links in the cornea, and cornea becomes stiffer. This is a classical experiment. You see here the cornea before. This is a control cornea before cross-linking, and this is the cornea after cross-linking. You see how it is stiffer. So now, because it's late, so I made it a little bit lighter. So we have 3 movies. So this is corneal cross-linking. How we do it? So we do it in, this is in the laser operating theater. It's actually the very long procedure. It's easy but long procedure. It takes about 1 hour. So the first, you have to anesthetize the cornea. This is topical anesthesia. Then there is a long discussion if you should debride epithelium or not. Some do, some don't. You can do it also by laser. You can remove about 40 microns of epithelium, and then you can actually put the drops of riboflavin. We should be sure that the cornea is actually really full of riboflavin. So this is a solution of riboflavin, and after roughly 30 minutes, the cornea is ready. We are measuring the corneal thickness with pachymetry. We want that cornea is 400 microns at least, because once this would be less, there would be danger for corneal endothelium, and it can be damaged by UVA. So there are new protocols, and maybe it's a good idea, in case the cornea is thinner than 400, to decrease the time of irradiation. And this is already irradiation by UVA light for 30 minutes normally, and that's it. So here you see what we call intracorneal stromal rings. So these are PMMA rings, which are actually implanting intrastromally in 80% of the cornea. So you see there is a flattening effect of these rings implanted in the cornea. This is the OCT image. And this is how it works. You see, so when you would be in such a cone, this is the cornea, and if you do this, so it becomes flattened. So this is what do Keratoconus. And you see here in topography, this is before the treatment, this is after treatment. So the cornea becomes flatter. So now another movie. So this is how we do the implantation of intrastromal rings to flatten the cornea. So there are nomograms for this. We can implant them in 2 zones, 5.5 and 6 millimeters, according the pupil diameter, and also according the topography. You heard maybe about Intax. Intax is basically the variant of Keratoconus. We always mark the horizontal axis, then we mark the axis where the Keratoconus should be implanted, the center of geometrical center of the cornea. And then now we mark the zone which is 5.5 millimeters in diameter. We measure in the place of incision, we measure pachymetry perioperatively to count 80% of that. And actually the tunnel, you will see how we do the tunnel, can be done by femtosecond laser. There is a whole discussion what's better, if mechanical or femtosecond laser, but it can be done, and now we are doing it in AVC, can be done by interlace. This procedure is done mechanically. So there is a just philosophically question if, if you imagine what we do mechanically, we go in between the lamellae of the cornea. If we do femtosecond, we can actually cut few of the lamellae. So the question is if we are not compromising a little bit biomechanical stability. But there are some studies showing that actually the results, femtosecond and mechanical, are very similar. So femtosecond is of course more pleasant for the patient. So you see the tunnel formation and now the implantation of carotene. So in this case we are implanting 2 carotenes here. And this is the second one, a little bigger and thicker. More the ring is thick, more effect we have, more the ring is closer to the pupil area, also we have more effect. Basically this is a procedure for roughly 10 minutes. Now, of course, in cases when we cannot use these, let's say, more subtle techniques, there are, again, of course, keratoplasty we can use, but we are not using, we are using penetrating keratoplasty, it's quite rare. Mostly we are using now a deep anterior lamellar keratoplasty or automatic lamellar keratoplasty done by microkeraton, or a lamellar keratoplasty by femtosecond laser. And so here are some examples how look different keratoplasties, and I will show you how we are now operating doing the keratoplasty. So you see the big bubble technique, so we are putting the air in the stroma. So we are actually detaching the SMS membrane from the stroma by the air. Sometimes it doesn't work, so we can convert once we penetrate, so we can convert easily to penetrating keratoplasty. So now we are removing here the stroma. And we know that our SMS membrane is detached, so we are penetrating the deep layers of stroma. And now we are just cutting the remnants of the stroma. And you will see after a while there is just clean SMS membrane of the patient. Endothelium which will be left behind, and we will then prepare the transplant, which will be, there will be the SMS membrane and endothelium will be removed from the graft. So the graft will be transplanted without endothelium. Of course, we are trying to use now more subtle technique with using femtosecond laser. This is in progress. all these instruments seems to be a little rough for such a thin tissues. So that's why we are now converting to femtosecond technologies and all this, because but still, you see, the SMS membrane is in place with intact endothelium. This is new cornea without the cement membrane. Healing is faster than after PKP, and so this is the result. So let's continue. So now we are in the second phase, which is refractive phase. So after we stabilize the cornea, after we make the surface more regular of the cornea, so we want to correct refractive error. Of course, we can do it by classic correction, glasses, contact lenses. We can do it also by PRK, especially after the corneal graft, by LASIK. And so here you see topographic guided LASIK. So this is before, after, you see more central treatment. We can use phakic intraocular lenses. We do it very often after all these procedures. So this is ICL, this is artisan, but more because we were using it only in cases of hyperopic toric, but now we have this option in ICL also, so we are using mostly ICL. And in older patients we are using refractive lens exchange. So these are all toric lenses we are using nowadays. And just 3 cases I would like to present. This is 25 years old male, right eye, first form of keratoconus, vision, the visual acuity is 1.66, but left eye there is a progression of the keratoconus, so we indicated Keratoconus treatment and corneal crosslink. And you see the before the therapy and after here. And actually the changes in keratometry is, I cannot see it, maybe it was closer, but it's roughly 10 diopters. And here, pre-op, you see uncorrected visual acuity down here is 0.005, and best corrected was 0.2 with -10 and -4 SIL. Post-op, the uncorrected was 0.6. And best corrected 0.8 with -1 SIL. This is actually exceptionally good result after Keratoconus. We are never promising to the patient better actually visual acuity, but in this case it worked actually very, very well. Then second patient is 37 years old male, keratoconus both eyes. He doesn't support any more contact lenses. So this was his pre-op data. OD, the visual acuity 0.1, uncorrected 1 with -2.5, -1.5 SIL. So, and left eye 0.05 and best corrected 0.8 with 5.5 SIL. So, first step, OS Keratoconus implantation. The best corrected visual acuity improved to 0.9. We decreased cylinders. Second step, OD, we implanted toric ICL star and we improved the uncorrected visual acuity to 6.6. And the third step, in the left eye after Keratoconus implantation, again toric ICL, and also in this eye we achieved a vision 6.6. So this was treatment in this patient. And the last patient is from AVC. This is a 54 years old patient. And his visual acuity in the right eye, uncorrected, was 660, left eye 160, corrected 6.75 with this correction, and 610 with this correction. So plus 5.5 and -9 cylinders in 90. So we decided in this patient for refractive lens exchange. In right eye, we managed with acrys of toric, and in left eye, we implanted Reiner toric, which was plus 15, plus 11 cylinders, which was not enough, and then we add actually piggyback lens, Reiner Silkoflex toric. So there were 2 lenses in the eye, and we add -1 plus 6 cylinders, and the result was 3 months post-op. Uncorrected visual acuity, right eye 6.6, left eye 6.9. So here I'm just showing you, this is our new algorithm, how we are dealing with keratoconus. It depends if there is a progression, irregularity, so then according this we go for corneal cross-linking. If there is irregularity, we use cross-linking and intracorneal rings, CK and topography guided PRK. And in case there is no possibility of this treatment, we are going for keratoplasty, usually DALK. And then in the second step, we are treating the patients, we do for second step, which is refractive treatment, and we are using toric IOLs, PRK, LASIK, phakic IOL in general. And of course, in patients they don't want, we use still contact lenses and glasses. And I think this is the last slide. Thank you very much.